Bismillahirrahmanirrahim. Quote of the day: a good teacher is like a candle, it consumes itself to light the way for others. Today's topic of presentation is dog bite. I'll be presenting this topic under guidance of my kind supervisor, Professor Dr. Sara Afzal. Learning outlines: dogs and victims, causes, mortality, morbidity, causes, rabies virus, transmission, symptoms, rabies vaccine, post-exposure prophylaxis, pre-exposure prophylaxis, test for rabies, management, recent updates, MCQs. Learning outcomes: at the end of this presentation, participants will be able to describe about the dog bite, its causes, symptoms, diagnostic test, vaccination, management. Dogs: prominent canine teeth, enormous pressure when biting, large breeds tend to cause wounds in the head and neck, powerful jaws can penetrate the skull and destroy deep tissue. Victims: males are more likely to be bitten by dogs, females are more likely to be bitten by cats. Animal bites are most common in children aged 5 to 14 years. Causes of provoked attacks are antagonizing an animal, hurting an animal. Causes of unprovoked attacks: approaching the young of an animal, approaching an animal that is eating, entering the property of a territorial animal, nearing an animal with rabies. Mortality or morbidity: wound infection and cellulitis, puncture wounds have a higher rate of infection than laceration. Lacerations cause more damage to tissues than puncture wounds. Septic arthritis from wounds in joint spaces. Osteomyelitis from deep wounds. Meningitis from penetrating skull wounds. Rabies. Rabies. Epidemiology: acute rapid progressive and highly fatal viral disease of CNS caused by Lyssa virus type 1, zoonotic disease of warm-blooded animals, dogs, cats, bats, raccoons, skunks, and foxes, transmitted to man by bite of rabid animal, non-bite exposures, aerosols generated in labs, caves with bats, corneal transplantation, human-to-human transmission extremely rare, worldwide endemic canine rabies, 55,000 deaths annually, India alone 20,000. Louis Pasteur and Emily Rocks first developed rabies vaccine in 1885. Causative agent: rabies virus belongs to family Rhabdovirus, genus Lyssa virus, and serotype 1. Bullet-shaped neurotropic single-stranded RNA non-segmented antisense genome consists of 11,932 nucleotides and encodes 5 proteins. 6 other non-rabies virus species in Lyssa virus genus have been reported to cause a clinical picture similar to rabies. So here is the rabies virus. Rabies virus is a G glycoprotein spikes, M protein, lipid bilayer membrane, a helical nucleocapsid RNA plus N protein, and polymerase 2 proteins. Rabies host: rabies virus can infect any mammal, which then can transmit disease to humans. True animal reservoirs that maintain the presence of rabies virus in the population are terrestrial, carnivores, and bats. Worldwide transmission from dogs accounts for more than 90% of human cases. In Africa and Asia, other animals serve as prominent reservoirs, such as jackals, mangostes, and raccoon dogs. Rare in small mammals, including mice, squirrels, and rabbits. To date, no animal to human transmission from these animals has been documented. So here is the pictorial representation of some of the reservoir species of terrestrial rabies. You can see like there are hyenas, dogs, red foxes, etc. Scenario: in world estimated to cause 59,000 human deaths annually in over 150 countries, with 95% of cases occurring in Africa and Asia. 99% of rabies cases are dog mediated. Approximately half of the cases attributable to children under 15. Major burden in Asia, with an estimated 35,172 human deaths per year. And India accounts for 59.9% of rabies deaths in Asia and 35% deaths globally. Human deaths from rabies. Here you can see different areas being highlighted. The red area is showing that these were more than 8,100. Presence and absence of rabies worldwide. The data is being collected in 2005. So here you can see different highlighted areas showing the absence and presence. You can see the presence of rabies worldwide. Rabies countries or areas at risk. You can see the high risk areas being highlighted here, which are showing the rabies and the countries which are being which are at the risk of rabies. Transmission: humans most often become infected with rabies through the bite or scratch of an infected dog or cat. Routes of transmission have been documented and include contamination of mucous membranes, that is eyes, nose, mouth, aerosol transmission, and corneal transplantations. Rabies virus can be excreted in the saliva of infected animals several days before illness is apparent. Pathogenesis. Incubation period is 20 to 90 days. Stages virus inoculated by bite replication in mucous muscles. In replication in muscles, virus binds to nicotinic acetylcholine receptors on postsynaptic membranes at neuromuscular junction. Retrograde axonal transport spreads centripetally along peripheral nerves towards CNS 250 millimeter per day through local dorsal root ganglion spinal cord. CNS dissemination, centrifugal spread along sensory and autonomic nerves. So here you can see that there is a dog bite and the virus inoculated virus replication in muscle. And then there's virus, the virus binds to the nicotinic acetylcholine receptors at neuromuscular junction. And then there's virus traveling with axons in peripheral nerves via retrograde fast axonal transport. And then there would be replication and then centrifugal spread along the nerves to salivary glands, skin, corneal, and other organs. And then there is infection of brain neurons with neuronal dysfunction. Most characteristic pathological finding are the Negri bodies, eosinophilic cytoplasmic inclusions in neurons composed of rabies virus protein and viral RNA, not observed in all cases of rabies, commonly seen in hippocampus and cerebellum. Basis for behavioral changes, including aggressive behavior, is not well understood. Lack of prominent degenerative neuronal changes has led to the concept that neuronal dysfunction rather than neuronal death responsible for clinical disease in rabies. So histologically, you can see the Negri bodies and cytoplasm of cerebellar Purkinje cell. Clinical features, incubation period is 1 to 3 months, 5 days, more than 6 months. So types are encephalitis or furous rabies, paralytic or dumb rabies. Here are some clinical features differentiating these two as well. Furous rabies affects 80% of infected people. There would be paranoia, terror, hallucination, and finally there would be delirium, insomnia, and there is hydrophobia, fear of water, over salivating, difficulty swelling, extremely painful muscle spasms in the throat and larynx, and there would be panics at the sight of water, unquenchable thirst, hyperactivity, and death by cardiac arrest. In the paralytic rabies, it would be like affecting 20% of the infected people, less dramatic and usually longer course than the furous rabies. And there is gradual coma, there is no hydrophobia, muscle weakness and loss of sensation, paralysis, and death. Symptoms are as follows, depending on the different periods. Incubation period would be 20 to 90 days, and they would be asymptomatic. Prodromal period enters the CNS 2 to 10 days. There would be fever, malaise, anorexia, headaches, nausea, emesis, agitation, and diarrhea. Neurological period, objective signs of developing CNS disease 2 to 7 days. Psychosis, restlessness, seizures, aphasia, hydrophobia, aerophobia, signs of cranial involvement, diplopia, facial palsy, and optic neuritis, and there would be coma and death ultimately. Test for rabies. Rabies diagnosis in animals after the animal is dead. Direct fluorescent antibody is the gold standard diagnostic method for rabies. Tissue for at least 2 locations in the brain, preferably the brainstem and cerebellum, would be taken. And then rabies diagnosis in humans. Tests are performed on samples of saliva, serum, spinal fluid. Skin biopsy specimens are examined for rabies antigen in the cutaneous nerves at the base of hair follicle. Rabies virus is not found in blood, urine, or feces. Treatment, no established treatment yet, and isolation in quiet room as bright light, noise, cold draughts precipitate spasm and convulsions. Sedatives to relieve anxiety, hydration, intensive respiratory and cardiac support. Prevention, post-exposure prophylaxis, local wound care, all white wound scratches washed with soap and water reduces chances up to 80%. Devitalized tissue debride, tetanus prophylaxis given, suturing delayed if necessary, done after 24 to 48 hours. Antibiotic treatment whenever indicated, active immunization by rabies vaccine, passive immunization by human rabies immunoglobulin. Recommended post-exposure prophylaxis, there would be administration of single dose of anti-rabies serum with course of vaccine together with local treatment of wound is best specific prophylactic treatment. After exposure of man to rabies, stop treatment if dog remains healthy or proven to be negative for rabies by reliable lab using diagnostic techniques. So here's a table showing type of contact exposure and recommended post-exposure prophylaxis. There are 3 categories. Category 1 is the type, they are divided on the basis of type of contact. So, and then I'll be telling the recommended post-exposure prophylaxis basis on that. The first category is touching or feeding of animals, licks on intact skin, contact of intact skin with secretions or excretions of rabid animal, human case. There would be like no recommended post-exposure prophylaxis if reliable case history is available. In the category 2, there would be nibbling of uncovered skin, minor scratches or abrasions without bleeding. There would be wound management in this category, and anti-rabies vaccine would be given. So in the category 3, there would be single or multiple trans-double bites or scratches, licks, or on broken skin. And contamination of mucous membrane with saliva, that is licks. So there would be wound management, rabies immunoglobulin would be given, and anti-rabies vaccine would also be given. So it is emphasized that post-exposure prophylaxis should be started as early as possible after exposure. However, PAP should not be denied to person reporting late for treatment, as explained. Wound management, there are some do's and don'ts. So do's are physical, chemical, and biological. In the physical, we have to wash with running water within 15 minutes. It should be done ideally. Mechanical removal of virus from the wound. Chemical, wash the wound with soap and water and apply disinfectant. Inactivation of the virus. Biologically infiltrate immunoglobulin into the deep and around the wounds. In category 3, exposures. Neutralization of the virus. Don't do not touch the wound with bare hands. Apply irritants like soil, chilies, oil, lime, herbs, chalk, betel leaves. Prevention. Health personnel should wear face mask, gloves, goggles and aprons. Saliva, vomit, tears, urine, or other body fluids of rabies patient contain virus. Persons having bruises, cut, or open wounds not entrusted to look after patients. Pre-exposure prophylaxis, post-exposure prophylaxis. Indication of anti-rabies treatment of if animal shows signs of rabies, that is die within 10 days of the observation. If biting animal cannot be traced or identified, unprovoked bite, all bites by wild animals, lab tests, fluorescent rabies antibody test for negative bodies in brain of biting animal positive for rabies. Types of rabies vaccine. So there are different types of rabies vaccine. Here are some: nervous tissue vaccine, suckling mouse brain vaccine, duck embryo vaccine, purified duck embryo vaccine, human diploid cell vaccine, second generation tissue culture vaccine. That is A and B, purified chick embryo cell vaccine and purified viro cell vaccine. Together, they're called cell culture vaccine. So in the government of India stopped producing neural tissue vaccine in 2004. Purified duck embryo vaccine and purified chick embryo vaccine available in the India. Intradermal schedule. 22202 updated Thai Red Cross schedule. That is also called, these are the two names used for each other. So 2 sites intradermal vaccination has been used in India endorsed by WHO expert committee on rabies. 0.2 ml doses given at each 2 site on day 0, 3, 7, and 28. Intradermal dose is 1/5 of intramuscular dose. Rabies vaccine. In previously unvaccinated 5 intramuscular doses, day 0, 3, 7, 14, and 28 previously immunized. 2 booster doses, day 0, 3 given. In pregnancy, not a contraindication for immunization. Glucocorticoid immunosuppressants should not be administered during post-exposure prophylaxis unless essential. Rabies immunoglobulin passive antibody is present 24 hours after injection. Half-life of approximately 21 days. Dosage is that is human rabies immunoglobulin is 20 international units per kg, and equine rabies immunoglobulin is 40 international units per kg. Admin as soon as possible at the same time as vaccine or up to 7 days after the vaccine injection. Human rabies immunoglobulin is purified from serum of hyperimmunized human donors. Single administration at site of bite, virus present at bite site during most of the incubation period. Given in less than 7 days after first vaccine dose. After 7 days, endogenous antibody produced and passive immunization may be counterproductive. Human rabies immunoglobulin much tolerated than equine derived. Doesn't require prior sensitivity testing. Local pain and low-grade fever may occur. Severe adverse effects are uncommon. Previously unvaccinated, human rabies immunoglobulin 20 international units, 40 international units purified equine rabies immunoglobulin after test dose. If human rabies immunoglobulin not available, should be infiltrated at site of bite, remaining given intramuscular at distant site from bite. If mucous membrane involved, entire dose should be given intramuscular. If multiple and large wounds, rabies immunoglobulin should dilute it to obtain sufficient volume for adequate infiltration. Number 2, they will be those who are previously immunized, rabies immunoglobulin should not be given. Pre-exposure prophylaxis. For people with occupational or recreational risk of rabies, including travelers to rabies endemic areas, have primary schedule consisting of 3 doses, 0, 7, 21, or 28 per day. After one month, if virus neutralizing titer is less than 0.5 international units per milliliter, booster dose given. Further at intervals of 2 years as long as exposed person at risk. Previously immunized person, 2 intramuscular intradermal doses should be given at day 0 or day 3. Rabies immunoglobulin should not be given. Full post-exposure prophylaxis should be given to persons who receive pre or post-exposure prophylaxis with vaccines of unproven potency. Patient whom immunological memory is not longer assured as a result of HIV or AIDS or other immunosuppressant causes. So this table is showing re-exposure rabies treatment, time after previous vaccination, the schedule, and the recommended vaccination. If there would be less than 15 days, there would be the schedule would be complete or incomplete. Vaccine doses are not recommended. Indicate vaccine doses need to complete the schedule in incomplete case. Between 15 and 90 days, in the complete case, there will be vaccine doses are not recommended in incomplete case or the schedule. 1 or 2 doses. Indicate 4 vaccine doses on days 0, 3, 7, 28. In the case of incomplete 3 or 4 doses, indicate 2 doses on day 0 and 3. After 90 days, complete in the complete schedule case, indicate 2 vaccine doses on day 0 and 3, and in the incomplete case, indicate complete schedule. World's Rabies Day is September 28, cooperative global event planned to reduce suffering from rabies. This day celebrates Dr. Louis Pasteur's vision of rabies-free world. Recent advances. Rabies virus infection and update abstract. There are still many unanswered questions in the pathogenesis of rabies, but recent progress has been made. During most of the long incubation period of rabies, the virus likely remains close the site of viral entry. Centripetal spread to the central nervous system and spread within the central nervous system occurs by fast axonal transport. Neural dysfunction rather than neural death is responsible for the clinical features and fatal outcomes in neutral rabies. Recent work has changed our perspective on the ecology of rabies virus under the particular circumstances in certain species. Hopefully, advances in our understanding of rabies pathogenesis will lead to advances in the treatment of this dreaded disease. Post-exposure treatment of rabies in Pakistan. Abstract to evaluate compliance with current World Organization WHO guidelines for post-exposure treatment of rabies. We interviewed all animal bite victims seeking treatment on the same day of each week from 28 December 1994 through 18 January 1995 at the Civil Hospital of Karachi, a major referral center of the 143 patient studies. 109, 76% sustained bleeding, transdermal bites WHO category 3. Overall wounds were not washed with soap or antiseptic in 69% of victims. All victims received 5% sheep brain-derived vaccine, and only 3 of the 109 victims with category 3 bites received rabies immunoglobulin. Post-exposure treatment of rabies in Karachi was deficient by all WHO standards. Although there is a great urgency to improve post-exposure treatment, it will remain a costly and inefficient method of controlling rabies. Reduction of rabies reservoirs is required to decrease human deaths due to rabies in Pakistan and other developing countries in which canine rabies is endemic. Time for MCQs. MCQ number 1, rabies virus is a flavivirus. B is transmitted by aerosolized secretions. C is a reverse zoonosis. D is more likely to cause paralytic rabies in dogs than in other non-human animals. Paralytic rabies does not occur in rabies. Anyone? It's B. It is transmitted by aerosolized secretions. MCQ number 2. After a patient sustains a bite from an animal infected with the rabies virus, the virus is initially transported to the brain through which of the following? A, circulatory system. B, spinal cord. C, lymphatic system. D, peripheral nervous system. E, spinal cord.
Delta.
Yes, it's delta. It's peripheral nervous system.
Delta.
MCQ number 3. A traveler comes to your clinic after getting 2 doses of a vaccine 6 months ago and next week is traveling to an endemic area for rabies. What should you do? A, start the scheduling again and get him to cancel his trip. B, get 1 dose of vaccine and assume he has good cover. C, order the same vaccine he used and give him 1 extra dose. D, assume he has already has good enough cover. E, no intervention needed. Anyone?
Alpha.
No, it would be B, give 1 dose of vaccine because the traveler already he's going to endemic area, and according to the schedule I just told you, we have to like give 1 dose of vaccine and assume he has good cover now. An adolescent comes to your clinic with diagnosis of rabies. He wants to inquire about rabies vaccination. Which of the following is false regarding the rabies vaccine? The rabies vaccine should never be given intravenously. B, the dosage is the same for children as it is for adults. C, human diploid cell vaccine can lead to ulceration if given intradermally. D, the vaccine is safe to give with live vaccines. E, it is an inactivated vaccine. Anyone?
E.
No, that is a correct one. It is an inactivated vaccine. It would be C, because there is no such a side effect of this human diploid cell vaccine. An adolescent was bitten by a stray dog. To rule out rabies in the animal, brain tissue sample was taken. Which part of the brain tissue should be taken to see the characteristic Negri bodies? A, hippocampus. B, hydrocephalus. C, medulla. D, midbrain. E, pons. It would be A, hippocampus. I already mentioned in the slide that you have to see it's A, either hippocampus or cerebellum. MCQ number 6, a wildlife officer comes to clinic for receiving prophylactic vaccine against rabies. How many doses of human diploid cell vaccine is needed for pre-exposure prophylaxis of rabies? A1, B2, C3, D4, E5. Anyone?
A.
No, it would be
E.
C. No, it would be C. We have to give 3 doses. I mentioned in the earlier slide in the pre-exposure prophylaxis. A patient presents to OPD with a history of dog bite by a stray dog. After complete history, doctor examined the patient thoroughly. Which among the following is not among the symptoms of rabies? A, hydrophobia. B, aerophobia. C, constricted pupils. D, seizures. E, agitation.
Beta.
No, it's Charlie, constricted pupils. These both are the symptoms. Seizures, agitation is also a symptom. MCQ number 8. A 44-year man has been bitten by a wild dog, resulting in multiple deep lacerated wounds on his left leg. He has a record of previous complete pre-exposure vaccination against rabies that he had taken 5 months back. He presents at the district hospital, where you provide him with the appropriate management, which should include all except A, washing wound with soap and water. B, giving rabies vaccine booster on day 0. C, rabies vaccine booster on day 3. D, apply povidone iodine on wound. E, rabies immunoglobulin on day 0. Anyone? It would
Delta.
be no, it would be E. That these 4 options are correct, because we have to like wash the wound within 15 minutes, and you can apply the disinfectant as well. So we have to give it was 5 months back, it is more than 90 days. So you can see that we have to give the booster on 0 and 3 day, and we cannot give the rabies immunoglobulin. You can, but it would be highly costly. A boy complained of unprovoked bite by a local dog in the community. The dog was later caught by the local animal authorities and appeared to be healthy. The most appropriate course of action would be A, give post-exposure prophylaxis to the bitten person with cell culture-derived vaccine, withhold vaccination, keep the dog under observation for sign of rabies. C, test the dog for rabies antibodies, immediately carry euthanasia of the dog, and no intervention needed. Anyone? That would be A, give post-exposure prophylaxis to the bitten person with cell culture-derived vaccination. MCQ number 10, as a 19-year-old male bitten by a street dog presents to the hospital with agitation, headache, fever, and confusion. On direct fluorescent antibody test, rabies was confirmed as the diagnosis. Which of the following is false statement regarding rabies infection? A, rabies is a dead-end infection in man. B, can be transmitted by aerosols. C, suturing is usually recommended on local wounds. D, human rabies immunoglobulin dose is 20 international units per kg. E, human bite cannot transmit rabies. Anyone? The answer would be C, because suturing is not recommended. All 4 options are correct. Here is the key of the MCQs. Here are some of the references. Thank you so much. Here is the link. Kindly subscribe and like. Thank you so much.
Thank you very much, Dr. Ramna. Very nice presentation, especially the part that you have presented in tables. That is the most wonderful part, and very good information has been summarized in the form of tables. The second important thing is you have